Hello everyone. So today we will be discussing about the ectopic pregnancy, not the ectopic pregnancy in detail, but only the troubleshoot series. That is what all mistakes you do in the quiz. Okay. So this is troubleshoot series is a special series in which I will be discussing about the mistakes which you are doing in spite of covering your syllabus. Okay. So please like, share, and subscribe my channel. It will help me a lot in my teaching journey. Okay, so here we start. So first of all, the question is, what is heterotropic ectopic pregnancy? Heterotropic ectopic pregnancy is the pregnancy in which there are two pregnancy. Other than intrauterine pregnancy, there is also a ectopic pregnancy. Okay, so there are two pregnancies. One is intrauterine and the other is ectopic. Okay, now how to manage this heterotropic ectopic pregnancy, that was the question. Okay, so to manage this pregnancy, we will not give methotrexate even if the pregnancy is unruptured and it is satisfying the criteria, because the methotrexate will kill the intrauterine pregnancy also. It might be that the patient wants that intrauterine pregnancy, right? So if we will ask the patient, if the patient wants intrauterine pregnancy, then we will remove the ectopic by laparoscopic salpingostomy if it is unruptured, and if it is ruptured we will do the salpingectomy. Okay, but we are not going to give the medical management methotrexate if the patient wants that intrauterine pregnancy. Okay, so never give the medical management in the case of the heterotropic pregnancy in which the patient wants that intrauterine pregnancy, because the medical management will kill the intrauterine and ectopic both. Okay, मेथोट्रेक्सेट को नहीं पता कि उसे सिर्फ एक्टॉपिक को ही मारना है, ठीक है, या उसने तो जाके जहाँ जहाँ पे प्रेगनेंसीज हैं उन सबको ख़त्म कर देना है, ठीक है, जहाँ जहाँ पे सेल डिवाइड कर रहे हैं उन सबको ख़त्म कर देगा मीथोट्रेक्सेट, ठीक है। तो इसलिए मीथोट्रेक्सेट को नहीं पता है ना, ठीक, इसलिए हम उस जो हमारी एक्टॉपिक प्रेगनेंसी है उसको हम सर्जरी से रिमूव करेंगे। ओके, बहुत बार हिट्रोट्रॉपिक प्रेगनेंसीज होती हैं आईवीएफ कंसेप्शन में, तो आप जानते ही हो कि आईवीएफ में बड़ी मुश्किल से बच्चा ठहरा है, तो लेडी विल बी वेरी पर्टिकुलर अबाउट गेटिंग दैट चाइल्ड. Okay, so you are not going to abort the intrauterine pregnancy if the patient wants. Okay, so you have to take the consent. Okay, so now about the investigations in ectopic. Okay, the most useful, now when we have a doubt of ectopic pregnancy, the first and the most useful investigation which we go for is transvaginal ultrasound. Okay, the first and the most useful pregnancy for which we go for is transvaginal ultrasound. You all know that in ectopic pregnancy there is no gestational sac in the uterus. There is a annexal mass in the ectopic pregnancy. Okay, so in by transvaginal scan, we in a very early period of gestation we can appreciate that there is no gestational sac in the uterus, or we can say the uterus is empty and there is a annexal mass. By transvaginally we can very easily differentiate. Okay, so whenever we have a suspicion of ectopic, so the first and the most useful investigation is TVS. Now some of the students, they ask me, ma'am, the first investigation is beta HCG. No, beta HCG is not a first investigation. If we are left with no confirmatory diagnosis on ultrasound, then we take the help of beta HCG. Beta HCG is not the first investigation. Okay, if we have any suspicion by transvaginal ultrasound, for example, in transvaginal ultrasound, if we don't get gestational sac and we don't get adnexal mass, Rana. So then we will go for the beta HCG. Okay, the confirmatory investigation no doubt is laparoscopy, but usually we go for transvaginal ultrasound. HSG. Today I put the question that whether the HSG is useful or not. How a hysterosalpingograph will be useful? You tell me. We have to find that whether that gestational sac is in the uterus or in the adnexa, in the fallopian tube. So how we will find out it by HSG? No, we cannot find out, right? So HSG is not at all useful. Now how we will find out? By bimanual pelvic examination. Beta, if it is a uterus pregnancy, then the uterus size will increase, right? And if it is a ectopic pregnancy, then uterus will be of normal size. Okay, so bimanual pelvic examination help. HSG does not help. HSG के तो दो ही काम है, एक तो यूट्रस की कैविटी की शेप बताना. So in that case, it is helpful in bicornuate, septate, uterine diadelphus, in all that uterus. Okay, then the second use of HSG is for the tubal patency. In that case, it is useful in infertility, the pelvic infection, TB, in all those cases. In ectopic pregnancy, in pregnancy, no use. And don't you know that in HSG we do X-ray in the cervix via the Leach-Wilkinson cannula? We instill the radiopaque dye and then we take X-rays. Will you do HSG in a patient in which you are having the doubt of X-ray and you are having the doubt of in which will you do a X-ray in a patient in which you are having a suspicion of ectopic or intrauterine pregnancy? Will you do? How come? And how we will identify the gestational sac on HSG? No, we cannot identify. Okay, so by bimanual pelvic examination it helps, because bimanual pelvic examination tell us about the uterus size. If the size is normal, then it is the ectopic pregnancy. If the uterus size is increased, then it is yes, intrauterine pregnancy. Okay, so this was about the investigation. Now let us see treatment. Same, this question was there in your quiz today. Treatment of ruptured ectopic: blood transfusion followed by laparoscopy, immediate laparotomy. Okay, first make a thing clear. ठीक है, in the ruptured ectopic pregnancy, from the site where the tube has ruptured. Okay, why tube ruptures? Because as the tubal pregnancy progresses, it stretches the fallopian tube, and at one time when the tube cannot not stretch more, it ruptures. And from the site where the tubes ruptures, lot of bleeding is being occurring. Okay, and peritoneum is full of getting full of blood. पेरिटोनियल कैविटी में लगातार ब्लीडिंग हुए जा रही है रप्चर ट्यूब वाली जगह से. ओके, लगातार. दैट इज व्हाट इज रप्चर्ड. दैट इज व्हाई इट सेज कि रप्चर्ड एक्टोपिक का इमीडिएट लैप्रोटमी करो. इसीलिए तो लेटर ऑन द पेशेंट ऑफ रप्चर्ड एक्टोपिक हैज हाइपोटेंसिव शॉक, एंड इफ वी डोंट डू द लैप्रोटमी ऑन टाइम or earliest, then the patient will expire. Just as in the case of PPH, आपको डर लगा रहता ना ये ब्लीडिंग बंद नहीं हुई तो पेशेंट एक्सपायर कर जाएगा, बिल्कुल उसी तरह यहाँ भी पेशेंट के पेट में ट्यूब रप्चर होने के बाद लगातार ब्लीडिंग हुए जा रही है. ब्लीडिंग इज बीइंग कॉन्टिन्यूस. इंट्रापेरिटोनियल हैमरेज, जो कि आई हैव टेकन आउट ऑलमोस्ट, you can say, such a big clot from the patient of ectopic pregnancy. Okay, now patient do delay due to their lack of awareness, but why we should delay? So why we want to do laparoscopy along with blood transfusion? No, first we have to, yes, we, if the option is laparotomy plus blood transfusion, so we will take that. Okay, but our first concern is to stop that ruptured tube which is bleeding and bleeding and bleeding. Okay, our first concern should be to stop that bleeding. Okay, yes, once the patient is shifted to OT, then we can think of all these other things. Okay, so first concern, if blood transfusion and laparotomy both are given, then you will mark blood transfusion and laparotomy. If blood transfusion followed by laparo is given, you are not going to mark that. Your first concern is always and always to do the laparotomy and stop the bleeder. Okay. Okay, this is a lady presents with 3-month amenorrhea. This was a question which I gave today, and a lot of you did it wrong. Lady presents with 3-month amenorrhea and hypotensive shock. ओके, एमिनोरिया एंड हाइपोटेंसिव शॉक मेडिकल में और कोई कंडीशन नहीं है, सिर्फ एक्टोपिक ही है. प्रेग्नेंट लेडी को अर्ली प्रेगनेंसी में अगर उस लेडी का शॉक हुआ है तो पूरी मेडिकल साइंस में और कोई कंडीशन नहीं है. देयर इज ओनली वन कंडीशन, एक्टोपिक प्रेगनेंसी. व्हाट इज द साइट ऑफ इम्प्लांटेशन? ओके, नाउ यू ऑल नो that ampullary is the most common site, isn't it? Because fertilization occurs here and ampullary is the widest part. Ectopic ruptures here at 8 to 12 week. Okay, isthmus is the second narrowest part. Okay, and ectopic pregnancy ruptures around 4 to 6 weeks. Interstitium is the most narrowest, but it is supported by myometrium. So ectopic pregnancy goes up till 16 to 20 weeks. Okay, because in the question it was given 3 months amenorrhea, then the answer is ampullary. Okay, don't get confused. It is a rupture ectopic. They have given you a time of rupture. So you all know isthmus rupture early, interstitium ruptures very late. So the answer is ampullary. Okay, next is ovarian pregnancy, abdominal pregnancy and cervical pregnancy. See their criterias. We have not to learn any other criterias, we have just to learn the name. That much is sufficient for us. Now how to learn this name? Okay, just listen to this. Mnemonic will be clear to all of you. Okay, just listen here. Ovarian pregnancy, okay, and abdominal pregnancy. There are two type of people who study. One, who maintain their weight and everything when they study. Okay, and two, who are not able to maintain their health when they study. Quite often they gain the weight when they study. Okay, so these are the two type of the people who studies. So when a female weight is maintained, then a female does not suffer from PCOD. It means its ovaries are healthy. Okay, okay, so ovary is healthy in special people who are able to give a balanced approach to their studies, or they are doing the smart study. Okay, Other than tubal pregnancy, you all know tubal pregnancy is the most common pregnancy, and it is found in 95% of the ectopic pregnancies. After tubal pregnancy, ovarian pregnancy is the second most common ectopic pregnancy site of ectopic, and its criteria is Spiegelberg, because ovaries are healthy in special and smart girls. Okay. Abdominal pregnancy, now the who are not stirring smart or who are stirring foolishly, their abdomen increases. So abdominal pregnancy is criteria name is to deform. Okay. And this as you all know, abdominal pregnancy is a pregnancy which whose implantation is in the peritoneal cavity, and peritoneum has lot of space. If the zygote gets some suitable condition, then this abdominal pregnancy can progress up to 40 weeks. ओके. सर्वाइकल प्रेगनेंसी, सर्विक्स पे जो प्रेगनेंसी होगी, द एज दिस इज द मोस्ट रेयर प्रेगनेंसी, सो इट्स क्राइटेरिया इज रूबिन ऑफ पालमेन, विच आवर इज लेफ्ट आफ्टर स्पीजन एंड स्टूडिफॉर्म इज the cervical pregnancy. And this is NEET PG 2022 question, that the cervical pregnancy bleeds a lot and lot. Okay. In very early period of gestation, it bleeds a lot because cervix is full of vascular supply. So cervical pregnancy patient bleeds a lot. So now let us see some term. Laparotomy. What is laparotomy? So dear students, there are two ways you can approach the peritoneal cavity. Okay. One is when you this is the abdomen, you give an incision to the abdomen and layer by layer you enter into the peritoneal cavity. That is known as laparotomy. And what is laparoscopy? You insert a scope into the peritoneal cavity. That is known as laparoscopy. Okay. Okay. Then for example, if we want to do salpingectomy, the salpingectomy procedure is same. In the laparoscopy, when we have inserted like this the scope, all the instrument will go through this scope. Sometimes we insert 2 scopes, sometimes we insert 3 scopes. Okay. So but all the instrument will go through this scope. In the laparotomy, we have given the incision. Okay. So all the instrument will go through this incision. As the incision is very wide in laparotomy, so patient has lot of morbidity. Post operative patient needs lot of rest, and patient has to stay in hospital much more time. But this laparotomy in the wide incision procedure can be done in spinal anesthesia. Okay. So it can be also done when the patient is unstable. Let me tell you about laparoscopy. Laparoscopy is preferred as incision is small, so patient morbidity is decreased. So but this procedure decreased and patient has less hospital stay. It is very comfortable when we do laparoscopy ना, अगले दिन patient ward में चल रहा होता है. When the next day we go to take the round, we go to see the status, patient walks and says hello. Such a difference. And after 1 to 2 hours we discharge the patient. So it's such a lot of difference. And when we do laparotomy and do salpingectomy, then the patient has to be discharged after 3-4 days. Such a difference. Procedure is same, everything is same, but so fast is the recovery. But this laparoscopy is done under general anesthesia. So जनरल एनेस्थीसिया में हम क्या करते हैं, हम रेस्पिरेटरी रेट स्लो करते हैं, हम बीपी को थोड़ा डिक्रीज करते हैं, पूरी बॉडी का जो स्टेटस है वो थोड़ा कम कर देते हैं. इफ़ ऑलरेडी द पेशेंट इज़ अनस्टेबल, द वाइटल्स आर डिरेजिंग, देन इट इज़ वेरी रिस्की टू गिव द पेशेंट जनरल एनेस्थीसिया. ओके. So please don't say when the BP is 90 that we will do laparoscopy. You cannot do. Patient will die if we give the GA to the patient with unstable vitals. Okay, if the patient is unstable, then we will do laparotomy. If the patient is stable, then we will do laparoscopy procedure. Few more terms, hysterectomy and hysterotomy. First of all, ectomy means the removal of the uterus. Ectomy. Salpingectomy. Hysterectomy. So hysterectomy means removal of the uterus. Okay. Hysterotomy means giving a incision on uterus. In the same way we do salpingostomy. ओके, ऑटमी मीन्स इंसिजन देके जो कुछ करना है यूट्रस में कर लो और फिर उसको दोबारा स्टिच कर दो. ऑस्टमी मीन्स कि ऑस्टमी मीन्स उस इंसिजन को खुला छोड़ दो. अगर कोई टर्म ऐसे आएगी ना, हिस्ट्रोस्टमी है नहीं अभी, जैसे साल्पिंजोस्टमी. साल्पिंजोस्टमी का मतलब क्या है कि जो हमने इंसिजन दिया है उसको हम खुला छोड़ देंगे. और साल्पिंजोटमी का मतलब क्या होता है? ऑटमी मीन्स इंसिजन देके जो प्रोसीजर करना है कर लो और फिर उसको स्टिच कर दो दोबारा. ओके. hysterotomy is giving a incision on uterus and then again stitching it. And what is LSCS? LSCS is giving a incision on lower segment. Lower segment is made from isthmus. Okay. Lower segment is giving and then we take out the baby and then again stitch it. Okay. What is hysteroscopy? Hysteroscopy is inserting a scope into the uterine cavity or endometrial cavity and seeing all the endometrial cavity. So I hope all these terms are clear to you now. Okay. Now mesoprost is never used in ectopic. Lot of discussion was there today on this thing because mesoprost, what is the function of mesoprost? It induces contractions, uterine contraction, so it will expel out the uterine in pregnancy. It will not expel out the tubal pregnancy. So no use of mesoprost in the ectopic. Never to give. Okay, now let's see the mistakes of molar pregnancy. So what is molar pregnancy? Just listen here. Usually one ova and one sperm fertilize. Have you ever thought what will happen if one ova and two sperm fertilize? Okay, so first of all, when one ova and two sperm will fertilize, then the nucleus will be now triploid, isn't it? It will be triploid. ओके. अब जब दो स्पर्म एंटर कर गए हैं ओवा के अंदर तो कुछ धमाल तो होगा ना, कुछ प्रॉब्लम तो होगी. सो क्या होता है? ट्रोफोब्लास्ट keeps on proliferating and proliferating and proliferating. That happens. And these trophoblasts are not vascular. They are avascular. Okay. And these trophoblasts which are keep on proliferating, they slowly imbibe the water and they become swollen like cyst because these are avascular. ठीक है. पागलों की तरह ट्रोफोब्लास्ट प्रोलिफरेट करना शुरू हो जाती है जब दो स्पर्म्स एंटर कर जाते हैं. ठीक है. ओके. सो because mother ovum is present in the first case is so there will be formation of fetus, but no doubt this fetus will be anomalous or IUD, you can say. It will not have fetal cardiac activity. Okay, it will be anomalous fetus. Some fetus tissues will be there. Okay. And this is because some fetal tissue is there along with the trophoblastic proliferation, it is known as partial mole. So you will always remember कि partial mole में fetus है, मतलब one ova और two sperms fertilize किए तो triploid होगा. So don't forget कि partial mole triploid होगा कि नहीं होगा. ठीक है। अब और इसमें मेटर्नल और पेटर्नल दोनों कंपोनेंट होंगे, ठीक है। अदर निमोनिक विच आई गिवन टू गिव यू, T and P are nearby, okay, and D and C are nearby, okay. But how this complete mole is formed? Complete mole is formed when two sperms they fertilize an empty ova, because there is no mother nucleus. So now the genotype will be diploid and both the nucleus are paternal, and as no mother nucleus is there, so no fetus formation, okay. And those sperms will can only form molar pregnancy which are of X, which have X sex chromosome. You know that sperms can have Y chromosome also and X chromosome also, है ना. So the molar pregnancy is formed by those sperms which have X chromosomes, okay. Now you all know, because I told you this avascular hyperproliferated trophoblast is formed and it imbibes water and it becomes like cysts. So these all these cysts collectively they give the appearance of snowstorm appearance on ultrasound. But this snowstorm appearance is not found in choreo. Choreo is a cancerous situation. It is not a molar pregnancy. It is not something trophoblastic proliferation. It is a cancerous situation. Snowstorm appearance is not found in partial mole. Okay, because in partial mole there was some fetal tissue present. Okay, so this partial mole will look like missed abortion, some trophoblastic proliferation and some fetal tissue, dead fetus. So it will look like missed abortion. So you will not say that snowstorm appearance is found in vascular mole, because now you know that all these villi they are avascular. So snowstorm appearance is not found in vascular mole. So you have to see these words. So you will take that yes, in H mole snowstorm appearance is found, in complete mole snowstorm appearance is found, in vesicular mole the appearance is found. So what is the treatment of this molar pregnancy? For treating the molar pregnancy, you are never going to give the patient mesoprost, mifepristone, okay. You are never going to do DNC. You have to evacuate the cavity all of a sudden by suction evacuation. You have to give to evacuate all those cysts. You have to give a lot of vacuum pressure and then the cavity will get empty. Otherwise if you will do DNC or give mesoprost, then the patient will bleed like a hell, okay. And other than doing suction evacuation, you will follow up the, you all know that molar pregnancies, especially complete mole, they have a chance of becoming cancerous neoplastic condition in the future. So you will keep on following the beta HCG for 6 months, okay, because choreo they forms beta HCG. So you will keep on following the beta HCG of the patient every week for 6 months. That is why I say serial beta HCG monitoring is done in molar pregnancy, okay. And then we will give now as we will say the patient to not to conceive. Why is it so? Because by conceiving also beta HCG increases, okay. And by the when molar pregnancy changes into neoplasia, neoplasm, then also the beta HCG will increase. So we'll not come to know that whether this beta HCG increase is due to pregnancy or it is due to the molar pregnancy neoplastic condition. So we'll say the patient not to conceive, okay. For how much time? For 6 months. So what is the treatment of molar pregnancy? You will see three things in together: suction evacuation, beta hcg follow up for 6 months, and combined oral contraceptive pills or contraception for 6 months. We don't give copper T as a mode of contraception because as the molar pregnancy uterus is a soft uterus, copper T can perforate it. Okay. Okay. Now, first of all, please get yourself clear with this term molar pregnancies and GTN. Okay. What is molar pregnancy? The one which we studied, partial mole and complete mole are the molar pregnancy. And what are GTN? Now, when these pregnancy they change into neoplastic condition, they are GTN, gestational trophoblastic neoplasia. Don't think कि partial mole and complete mole they are cancers. They are not cancer, they are just benign conditions. They can, complete mole can change into cancer, but complete mole itself is not a cancer. When it will change into cancer, then we will not say it complete mole, then we will say it, depending on the characteristic, we will say it invasive mole, placental site trophoblastic tumor, or choreo carcinoma. So in next time when I'm going on to ask which of the following is not GTN, you are never going to mark partial mole or complete mole. So what are the GTN? GTN are the cancer, and in the last stands for neoplasia. Okay, neoplasia, cancer. So next time you are not going to mark the partial mole and complete mole. Partial mole and complete mole, they are molar pregnancies and they are 101% benign conditions. Okay. Which of the following is not GTN? Partial mole and complete mole, they are not GTN. This molar pregnancy and GTN, they collectively they are known as GTD, gestational trophoblastic diseases. Okay, next slide is which molar pregnancy changes into GTN. So you should know which complete mole will change into GTN. It means then you are a good doctor if you know that. If you know that suspicion, this, yes, this patient will change into cancer. So which molar pregnancy changes into GTN? The patient, these are the factors which decide the risk. Okay, the age more than 40, if beta hcg is very high, more than 10 raised to power 5, and if uterine size is larger than the gestational age. Okay, if the uterus size is larger than the gestational age, it means already this trophoblasts, they have high potential of proliferating. If there is formation of bilateral theca lutein cyst, because HCG functions similar to as LH, so there is formation of theca lutein cyst in the ovary. And if there is formation of bilateral theca lutein cyst more than 6 cm, it means that this is a case of molar pregnancy. Slow decline in beta hcg level. Beta hcg levels, they are not declining. Okay, so age, beta hcg more than 10 raised to power 5, uterine size larger than the gestational age, bilateral theca lutein cyst more than 6 centimeters, slow decline in the beta hcg level. Here nowhere there is written suburethral nodule. Okay, now last two slides about the choreo-carcinoma. Choreo-carcinoma is the neoplastic condition which sometimes get form after the complete mole. Okay, it is most commonly this choreo-carcinoma metastasized to lung. जब भी कोई कैंसर लंग में चाहता है ना, हम समझ जाते हैं इसका सर्वाइवल नहीं होता, लेकिन कोरियोकार्सिनोमा में ऐसा नहीं होता. सर्वाइवल इज स्टिल गुड इवन इफ द कैंसर हैज मेटास्टाइज्ड टू लंग. Okay, and it's most commonly metastasized to lung. That is why the lung can spread is not keep in stage 4, we have kept in stage 3. Okay, and now in the choreo-carcinoma there is no snowstorm appearance in the uterus. Choreo-carcinoma is something cancer. Okay, beta hcg will be high. Snowstorm appearance, you will not found any snowstorm appearance in the uterus. Snowstorm appearance is found in complete mole. Now no trophoblastic proliferation. Now to hyper formation of beta HCG and neoplastic cells. And when there is spread to the lungs, then there is cannonball appearance in the lungs or in the chest X-ray. Okay, and now the choreo treatment is not suction evacuation, it is a cancer. It will have the treatment chemotherapy, radiotherapy, and the treatment of choreo is chemotherapy. Okay, to the low risk patient we give methotrexate, and to the high risk patient we give imaco. Okay, imaco regime. Usually low risk are asked, please, and multiple dose methotrexate is given, not single dose methotrexate. It is a cancer beta, we have to give repeated doses of the therapy. Okay, now in the last one slide is that even not only the molar pregnancy can change into GTN, abortions, sometime abortions and sometime normal vaginal delivery also change into the GTN. Okay, sometime the normal delivery and the abortions, they also sometimes change into GTN. So what will be the presentation when they change into GTN? They will, patient will keep on bleeding even after repeated DNC. For example, delivery happened, then again patient will bleed, we will think that it is retained placenta, it is secondary PPH, we will do DNC. Even after the DNC, again the patient bleeds, again the patient bleeds. Repeated bleeding after the multiple DNCs is indication of GTN. So this was a clinical condition which has been asked. So now you will know that even not only the molar pregnancy can change into GTN, the abortion and the NVDs, they can also change into GTN sometime, but it is very rare. Usually molar pregnancy changes into GTN. This was one thing. And if the normal delivery, after the normal delivery, a patient is getting repeated episodes of bleeding even after DNCs, then there is a doubt that it is GTN. And this GTN, which is after the normal delivery, this is very dangerous. It has very poor prognosis. And this is what I always ask you in the question. Okay, this has been asked multiple times in the past, this can be asked in your exam, so you will keep a note on this. That's all about the ectopic pregnancy and molar pregnancy. Will come soon with the next video, anomalies and aneuploidies. There were a lot of mistakes, so I decided to make a separate video. See you soon in the next video. Till then, take care and do subscribe, like and share my channel. It will help me a lot. Thank you.